What's Up, Doc Mike? Public Health on Call, by Johns Hopkins Bloomberg School of Public Health. Today's topic for January 31, 2021, Understanding and Addressing Vaccine Hesitancy. Thank you, Johns Hopkins Bloomberg School of Public Health.
Welcome to Season 3 of Public Health on Call, a podcast from the Johns Hopkins Bloomberg School of Public Health. I'm Josh Sharfstein, Vice Dean for Public Health Practice and Community Engagement and a former Secretary of Maryland's Health Department. Our goal is to bring scientific evidence and experience to the public health news of the day through informative interviews with scientists, community leaders, policy experts, public health officials, clinicians, and more. If you have ideas or questions for us to cover, please email us at publichealthquestion@jhu.edu. That's publichealthquestion@jhu.edu for future podcast episodes.
Hi, I'm Lindsay Smith Rogers, the producer of Public Health on Call. Thank you for joining us for Vaccine Week on the podcast. Today, in a special two-part episode, we look at the landscape of vaccine hesitancy and what can be done to address it. In part one, Hopkins vaccine safety expert Dr. Dan Salmon talks with Stephanie Desmond about his research on acceptability of COVID-19 vaccines in minority communities and the importance of listening to understand hesitancy to help people feel more confident. In part two, Dr. Rupali Lamay, a Hopkins expert in vaccine behavior and decision-making, talks with Dr. Josh Sharfstein about misinformation, why hesitancy around COVID-19 vaccines is different from anti-vax groups for diseases like measles, and creative strategies such as pre-bunking to address misinformation. Let's listen. Dan Salmon, thanks so much for joining me.
Thank you for having me.
So today we're going to talk about vaccine acceptability. And I understand that you've been doing some research recently, very recently, into the topic. And I'm wondering if you could sort of lay out the work you've been doing.
Yeah, so this is a project that's funded by the Robert Wood Johnson Foundation. And we're doing it in collaboration with a number of organizations that work with local, state, territorial, and tribal health departments. NACHO, ASO, AIM, and the National Indian Health Board. And our goal is to understand what people think about the vaccine and then to rapidly share that with local public health so they can tailor their immunization program to meet the needs of local communities.
Mm-hmm. And you're learning, what are you learning so far?
Well, so we've done our first wave, and we have several waves. We did a national panel survey in the first 2 weeks of December. We oversampled African American, Latinx populations. And then we did 25 community meetings, and they targeted African American, Native American, Latinx, and vaccine hesitant communities. So we finished up that first round. We've rapidly shared those results with local public health. And this is what we found generally. We found that about half the population really wants the vaccine as soon as they can get it. And that's really good news. So if we build it, they will probably come. And what they're looking for is easy access, to not have cost be a factor, and to get the vaccine in a COVID-safe environment. We have about 40% of the population, which we termed wait and learn. And they really haven't made up their mind. They want more information about the vaccine and about what the safety and efficacy looks like. They tend to be more likely to be African American. They tend to have less trust in local and federal public health. They're less likely to talk to their primary care provider. They're less likely to think vaccines broadly are safe. But they still haven't made up their mind. And in the community meetings, you could hear that these groups were really interested in getting more information they could trust. Many of the minority populations really saw COVID vaccine and COVID in the context of their world history. So as soon as we started talking about COVID vaccine, our people started talking about Tuskegee and other examples of where medicine and public health haven't served them well. Issues of racial inequality frequently came up, especially among the African American and Native American populations. But, these groups are still making up their mind. It's an incredibly important group for public health to work with. And then we had about 10% of the population that had already made up their mind not to get the vaccine. And these people were far more extreme in all of the areas I just talked about. They didn't think COVID was a big deal. They thought the pandemic was being overblown. They didn't trust the vaccine. They didn't trust government. And this is going to be a very hard group to move. And perhaps new information will change some of their minds, but they're already pretty formed views and probably very difficult for public health to work with.
Do you sort of put those people aside and then focus really on those wait and learn folks?
Well, I think, what can be done with that 10%, one should do, but it's probably not the most efficient use of resources. It's that 40%. I mean, our first focus has to be making a vaccine widely available for the half the population that wants it. Mm-hmm. And at the same time, we need to start working in those communities to reach out to those 40% and to connect with them in a meaningful, trustworthy way. And we need to start doing that now, because once that half the population gets vaccinated, we need to get through to that 40%. And it may not be easy to do.
Right. So what percentage of the population needs to be vaccinated in order to protect people?
Well, it's hard to say. With the current COVID that's been circulating, we need somewhere 60, 70% immunity in order to really have a high level of community or herd immunity. Mm-hmm. Now, keep in mind, the vaccine seems to be 95% effective. However, we're not vaccinating anyone under 16 right now. So when you take out those children's under 16, you now look at coverage at close to 90%. And it's actually probably more challenging than that. For one, that assumes homogeneous vaccine coverage. If you see geographical or social pockets of underimmunization, that can cause a real problem. And given the differences that we see in vaccine intention by population, there probably will be that social and geographical clustering. Additionally, if we see strains that are more easily transmissible, then we need even higher vaccine coverage.
Mm-hmm. When you see those numbers, and you also see the numbers you've collected, you must be concerned.
Yeah, I am. Now these data, like I said, are from the first 2 weeks in December. And since that time, FDA's VRBPAC has reviewed the data publicly by independent experts. They've given emergency use authorization. CDC's ACIP has reviewed the data and made recommendations on who should get the vaccine. There's been pretty good media coverage, so maybe things have gotten better. Mm-hmm. One thing we heard from a lot of people in December was they were waiting for millions of people to be vaccinated. So now we vaccinated millions of people, and maybe that will make them feel better. We haven't had major safety concerns arise. There's been some very rare issues with anaphylaxis shock, but it's been addressed and can be addressed, because as long as people wait after they get vaccinated and there's medical care available, it's not a good thing. It's scary, but it's treatable. So perhaps in the last month through this process, people feel more comfortable. We're getting ready to do another wave of surveys and another round of community meetings. And we're actually meeting with the same people we met before. So this lets us take their voyage with them and see how their thoughts and beliefs and intentions evolve over time.
And I guess you obviously don't know how their views will change, but you would hope that with sort of all the clamoring for the vaccine that we're seeing at this moment in time, that perhaps their desire to be vaccinated has increased.
Well, the grass is always greener, and people want what they can't have. Right. So perhaps the inadequate supply at first will help generate demand. Mm-hmm. Probably it will among some, but not others. But I guess we'll see.
It's interesting because we had so much concern that people wouldn't take the vaccine. And at this moment in time, there is such a demand for the vaccine. I know that I've spent time trying to help people who are eligible find appointments. They're very scarce. It's a problematic situation right now. But this is not necessarily indicative of how this whole process will play out.
Yeah, this is very early in the vaccine program. And what you're seeing is the most motivated of this 50% that want the vaccine. And especially people that are elderly, have comorbidities, that may have a lot of exposure because of work. So yeah, they really want the vaccine. Mm-hmm. I would love to get the vaccine. If my number was up, I would get it myself.
As would I. Of course, I think I might be the last person in line.
I think it'll just be a moment before you.
Exactly. So what can we do? How do we get people to want the vaccine going forward?
Well, a lot of what we need to do, I think there's a few things we need to do. One is there has to be clear federal leadership, and that leadership has to be transparent and clear and explain what we do know and what we don't know and what we're doing to figure out what we don't know and what the recommendations are. And if we can create more confidence in our system, our approach, that can help. I think at the local level, it's really up to local public health to work with their communities and to, build trusting relationships to try to overcome some of the historic mistrust and the disparities in health inequalities that plague minority populations. So that's a process that takes time. And we need to start doing that now.
Mm-hmm. And I know that we've been plagued with misinformation from the beginning of this pandemic. Every time I see some story written about some one person who got an allergic reaction, it makes me feel concerned that people are going to take that and say, forget it, I'm not going to take this vaccine.
Yeah, it could happen with a rare allergic reaction. I'm more concerned that there'll be coincidental relationships with background rates of disease, right? Bad things happen to people every day. If we focus on people 65 and older, and if you took a snapshot of everybody who was 65 and older today without a vaccine, you're going to have a large number of heart attacks and strokes and all sorts of medical health outcomes that are bad. So if you vaccinate everyone today, all those same things are going to happen tomorrow just by chance alone. And there's a risk that people will see this temporal relationship and be afraid that it's causal. It's especially problematic because, these vaccines cause fairly common short-term reactions from fever and achiness. And, about half the people that get it, especially after the second shot, and especially people that are younger, will feel pretty poor the next day. So you're going to have a chain of events where somebody gets vaccinated. The next day they have a fever, they feel achy, they stay in bed. And the next day something bad happens to them, whether it's, Guillain-Barré syndrome or a heart attack. And I'm not saying that this will happen because the vaccine causes it. I'm just saying this will happen by chance alone. And people tend to assume when they see in a chain of events that one causes the other. So, I think that's where we have more risk than a very rare anaphylaxis shock.
Mm-hmm. And I know you've studied sort of safety issues with vaccines in the past. Are we seeing anything at this point, or is it just too early to know?
Well, so far things, like I said, there are a lot of short-term side effects that, are fairly mild to moderate and resolve themselves. Anaphylaxis seems to be more common than other vaccines.
Mm-hmm.
Typically vaccines, about 1 in a million will have an allergic reaction. And the early data look like it's about 1 in 100,000. Mm-hmm. Though I suspect that as we understand it better, it's actually probably not that common. Perhaps more than 1 in a million. But, so far things look pretty good.
Yeah. This is all, it's all sort of coming together. I think it's, we've waited so long to get a vaccine, and now it brings in a whole host of new questions.
Yeah. Well, it's having a vaccine is great. But vaccines don't save lives. Vaccinations save lives. And simply having it available is not going to solve our problem. So, it's great that we're getting the vaccine produced. It looks very safe. It looks very effective. We have to get it out and distributed. And these are more difficult because of the cold chain requirements. But we need to make sure that people want the vaccine, that they understand what we know about it and why it's in their interest, that they trust what we're doing. And we have to be prepared for a real safety problem if it were to occur, but also these coincidental adverse events following immunization that may appear to be related. So there's still a lot of work to be done.
Dan Salmon, thank you so much for joining me.
Thank you.
In part 2 of this podcast, Dr. Josh Sharfstein talks with Dr. Rupali Lemay about what makes hesitancy around COVID-19 vaccines unique compared to anti-vax groups. Let's listen.
Dr. Lemay, thank you so much for joining me to talk about vaccine hesitancy for the COVID vaccines. I know you're doing a lot of work in this area. What are you hearing?
Yeah, it's a great question. Thanks so much for having me here. We have seen essentially from March until the end of the year, we have seen a decrease in the percentage of individuals that would be willing to get a vaccine as this pandemic has rolled on. So not great numbers. On the flip side of that, we know as healthcare workers are starting to get the vaccine, we are hopeful that by them speaking about it, we'll be able to persuade other people to get it.
So let me take you back to March then. What was the level of interest in a vaccine then?
Yep. So around March, it was between about 60 to 70%, and this was among all adults. It's a little bit different by gender. And as I'm sure you know, there are fewer African Americans as well as Hispanics that are willing to get the vaccine. So from March until about the end of the year, it has dropped about 10 percentage points overall. So we have seen a huge decrease with regards to willingness to get a vaccine.
Why do you think that drop happened?
It's a great question. I think there's a couple of reasons. One, there's a huge amount of misinformation that is unfortunately being spread through social media that individuals are consuming at rapid rates. Second, there is a perception that the process has been politicized because of what has been happening with regards to the political context. And third, I think the last piece is that recommendations are constantly changing. And for you and I, we might see that as science working. Other individuals see that as public health individuals don't know what they are talking about because we continue to change recommendations. So I think
even if the recommendations are like over 75, now over 65, that doesn't seem like that's changing about the vaccine, but that can be confusing to people.
That's exactly right. It sort of decreases credibility within public health agencies specifically.
What about the idea that as the vaccines were shown to be so effective, so much more effective than people really anticipated, that might have given a little bit of a boost to the numbers? Did you see that in the data you were looking at?
We did see that originally when we first saw numbers that came out from Moderna as well as Pfizer, because first of all, the numbers in terms of effectiveness were much higher than I think anyone would have predicted. I think the other piece, though, that maybe there was a slight initial bump, but the other piece related to this is the safety issue that we continue to hear. Individuals feel as though it wasn't tested in a huge number of individuals in the population across different segments of the audience, for example. And it was such a shortened time frame because of the EUA that individuals are worried about the safety of it.
Right. Of course, it was tested in tens of thousands of people. And but the shortened time frame is complicated to explain. And, you know, the fact that all the key steps were taken leading into that big phase 3 study, they just happened so quickly one after the other because of the investments that were made. That's a hard concept to communicate.
That's absolutely right. And what we have been trying to do is when we have been working with especially offices, including departments of health, as well as different political leaders, such as mayors, we have tried to urge them to communicate to the public that there was no shortcuts that happened. I think that's still challenging for people to understand and really believe because of the expedited process.
Got it. So we're still in a pretty difficult spot, still needing to increase understanding and acceptance. But I want to take a step back. I know you have done a great deal of work on understanding vaccine hesitancy and thinking about strategies around this issue, even for routine childhood immunizations. And I wonder how the hesitancy that you see for COVID-19 vaccines is similar to or different from that kind of hesitancy issue.
It's a great question. I think pre-COVID, essentially, we could talk about concerns in 4 large buckets, if you will. Concerns about ingredients, concerns about the schedule, concerns about side effects, and then low levels of risk perception. I think what we have seen since COVID has started is this idea of a huge level of distrust, the misinformation, and then the polarization of attitudes. And so it has really resulted in hesitancy that is quite different than what we were dealing with before.
What about the perception of risk? That should hopefully be higher for COVID, but maybe not necessarily.
Yes, it's an interesting point, and we have looked at risk perception, so looking at severity as well as susceptibility of disease over time. And unfortunately, because of the way that cases are going in the United States, most people now know someone that was either infected or has unfortunately died from COVID. So we are hoping as a result that we don't see as lower levels of risk perception that we typically see. However, we're still seeing huge pockets of hesitancy. So again, it's either that distrust and sort of misinformation is trumping the risk perception issue. And so there's going to have to be, I think, concerted efforts to really make sure people are trusting the process.
It's interesting that there is still an effective polarization on hesitancy, given that you have, a unique kind of political consensus around vaccination. You have both, the administration, the Democrats, the new administration, everybody saying the vaccines are safe and effective. And yet there's still a sort of a legacy of some of the finger pointing that was happening earlier.
100%. Vaccines, unfortunately, have always been a bit of a political issue. They should be apolitical by nature. They have been more political. Part of it has to do with this idea of trust and liberty and the underlying principles that individuals feel with regards to vaccine mandates, whereas where a lot of this stems from. And so we're still seeing huge polarization. If you look by state, if you look at how voters are especially voting in pre-election, looking at some of the numbers with regards to whether you affiliate with as a Republican or a Democrat, there was a marked difference with regards to willingness to vaccination.
I want to ask you about similarities between this vaccine hesitancy and vaccine hesitancy for childhood vaccines. One that occurred to me is that it may be a bit of a social phenomenon, that people hear from their friends and then pass on concerns. And before you know it, you have not like exactly 1 out of 6 people is vaccine hesitant, but you get areas and groups that are quite vaccine hesitant. Do you think that is the case here?
It's a great question. There's been a lot of work that's looked at clustering of attitudes, which is what you are referring to. So, for example, you compare and you look at data from 10 years ago, and there was a lot more crossover with regards to people that are pro-vaccine compared to those that are anti-vaccine. Those groups have become more separate and disparate, I would say. They also then cluster. So with regards to these types of attitudes, if you tend to be not willing to get a vaccine, you tend to hang out with other people that are not willing to get a vaccine. That, as you can imagine, causes issues with regards to trying to control a pandemic, because in the same way that misinformation clusters, we need to make sure that we're able to protect people within clusters so that the virus cannot infiltrate and continue to spread.
Right. So if you had 90% vaccination coverage, but all at 10% was in one area, you could have quite a big outbreak still.
That's correct. And that's exactly what we've seen in California, that there are disparate and very specific clusters of populations that will not vaccinate their children that have led to vaccine preventable disease outbreaks in the state.
Right. For measles, for example.
Correct.
So if I were ringing you up for good news, I would be disappointed.
Unfortunately, yeah. However, what I will say, though, is that the vaccine development process was, I think, concerning to a number of people because of the expedited timeline. However, now that a vaccine is available, we're starting to see healthcare workers get it. We're starting to see healthcare workers talk about it in a positive way. And so fingers crossed that this will continue to influence individuals as they're looking to people to provide them with information and guidance as to whether or not they should get the vaccine.
What else do you think is necessary to build confidence? I know that it's not a small thing that healthcare workers are getting vaccinated. People trust their doctor, their nurse. But what else?
I think first is transparency, and we have looked at this and examined this in a number of different ways. So to really maintain public trust, we need to be upfront about what is going on. So that's timely and complete information, acknowledging what we know and what we do not know, which sounds very simple, but you'd be surprised at how many individuals and political leaders did not do this. The other piece, I think, would be how to essentially announce early. So making sure that we are being upfront instead of letting misinformation get ahead of us, being able to thwart and talk about, we've heard these different types of rumors. This is what we know. This is what we don't know. And the third piece to me, I think that is so incredibly crucial is understanding and talking to individuals and having empathy that they have concerns. We live in a really uncertain time. People are really worried about a number of things. I think that sometimes individuals feel as though their concerns are very much dismissed. So taking time to talk to individuals as to why they might have concerns would go a long way.
So let's say you're working at the city or county or state level. You would really encourage people responsible for vaccination to work with medical leaders, clinicians, nurses, others, and to create all kinds of forums for engagement for people to be able to ask their questions without fear of, being shouted down, for example.
Absolutely. The other piece I would add to this is that because there has been a bit of a decline in trust in public health authorities in general, again, because people might feel as though the process has been politicized, it's been extremely important for cities to identify other community leaders outside of healthcare providers to talk to folks. So whether that's through religious groups, for example, that can be through other community groups, other individuals that have influence that would be willing to recommend and talk about the vaccine is also really important.
Any creative or innovative strategies you're thinking about or pursuing or hearing about?
Yeah, we're spending a lot of time trying to think about how do we mitigate misinformation on social media. That seems to be a huge cause for a lot of the concern that we are getting. One piece that we're trying to do there is we're trying to work hand in hand and look at some interesting strategies called pre-bunking, for example, and inoculation. So how do we make sure that people can recognize when things might not be true so that they can discern what is true and what is not true? That's one piece. The second piece, as I mentioned, is we have been spending time and thinking about how do we equip individuals that are not typically within the public health space. So as I mentioned, this could be religious leaders, this could be other community leaders, but to serve as essentially peer educators to disseminate information about vaccines and just recommendations in general. So really applying these two different types of approaches, I think, to try to increase vaccine acceptance.
How would a peer education model work?
Yeah, so it's been used pretty widely, especially within the HIV and AIDS context, for example. So essentially, you're equipping an influencer or a community leader about how to deal with questions that people might have about the vaccine, recommend the vaccine, and really focus on interpersonal communication techniques so that they're comfortable and able to discuss with people that they engage with as to why it's important for them to get the vaccine to protect themselves as well as their communities.
Yeah, I think that kind of training and mobilization could be quite helpful. I'll tell you one point that I find myself circling back to in these conversations, which is that while there may be some uncertainties still about the vaccine, there are an awful lot of uncertainties still about COVID-19. People can get sick and have all kinds of problems later. And everything, we're looking at is a comparison of, vaccination versus getting sick. And getting sick has all kinds of very serious consequences, not just including serious illness and death. How do you think about bringing in COVID-19 itself into discussions of the vaccine?
It's a great question. One thing that we don't want to scare people, and I want to just very much focus on that. I think that we want to talk about what are sort of the long-term effects, as you're referring to here, that some individuals are facing and experiencing months after they've been infected. And so we try to communicate to individuals that there's a lot of unknowns about the disease. One thing that we do know about the vaccine is that one, it's been tested in a huge number of individuals. Two, it has gone through a rigorous safety as well as efficacy process. And three, it is recommended because it is one way for us to quote unquote get back to normal life. And I think that appeal is maybe more pertinent and relevant than really focusing on, if you don't get it, these are the types of issues that you could face from long-term healthcare consequences. I think it's flipping that script just a little bit.
Got it. Okay. Well, thank you. Thanks for the instruction, as well as for all you're doing to help people really understand the value of vaccination.
Thank you so much for having me.
Public Health on Call is produced by Josh Sharfstein, Lindsay Smith-Rogers, and Stephanie Desmond. Audio production by Spencer Greer, Niall Owen McCusker, C.N. Oates, and Matthew Martin, with support from Chip Hickey. Distribution by Nick Moran. Production support from Catherine Ricardo and Neiman Outland. Social media support from Brenda Haggader, Grace Holes Fernandez, and Caroline Wong. Thank you for listening.